I'm Naoki Akioka from University of Toyama, Japan. I would like to talk about angioplasty of intracranial and carotid stenosis. The first topic is intracranial atherosclerotic disease, ICAT. Endovascular treatment for intracranial stenosis is PTA plus stent, PTAS, with a wingspan stent being the only one approved for use. Wingspan has open cell structure and self-expanding nitinol stent. Delivery system is over the wire type, and the diameter of the stent ranges from 2.5 mm to 4.5 mm. Stents are available in 3 lengths. What you need to know about the use of wingspan stent is a result of the samples published in 2011. This study was a randomized controlled trial that compared the outcome of best medical treatment and PTAS with wingspan for the intracranial stenotic lesions. The study enrolled 451 patients with a stenosis of 70% or more within 30 days of stroke or TI onset. A primary endpoint are stroke or death within 30 days and stroke in the territory of the qualifying artery beyond 30 days. At this study, enrollment was stopped after 481 patients underwent randomization because the 30 days rate of stroke or death in PTAS group was high. The primary endpoint was significantly higher in the PTAS group. 30-day stroke or death rate was 14.7% in PTAS group and 5.8% in BMT group. 1 year rates of primary endpoint were 20% in PTAS group and 12.2% in BMT group. The reason for this is that many events occur immediately after PTAS, and even in long-term follow-up, the difference in the event occurrence does not cross. Long-term outcome of the samples trial were published in 2014. The results show that the difference between the two groups never narrowed and that the BMT group was significantly better. So, how were the details of the best medical treatment in this study? Antiplatelet therapy with aspirin and clopidogrel combination, DAPT, and second is antihypertensive treatment, and the third is lipid lowering therapy, and the fourth is a lifestyle modification program. These are very strict medical therapies. There is a report in 2017 that in the real world, not all cases can be subjected to the same strict medical management as samples. In Japan, a wingspan stent approved in 2013 after investigator-initiated trial. However, the indication was limited in the following conditions. First is rescue stenting, emergency treatment for the vessel dissection, acute occlusion, or impending occlusion occurring during PTA. The second is retreatment after angioplasty, for which no other effective treatment is available. The results of the wingspan registry in the United States were published in 2019. Main inclusion criteria were limited to the medical treatment resistant regions, 8 days or more after the last stroke, and 2 or more stroke in the vascular territory of the stenotic region. The outcome was good, with the event rate of stroke or death within 72 hours were only 2.6%. The results show that perioperative complication can be kept low if the indication criteria are followed. These are 3 mechanisms by which intracranial artery stenosis can become symptomatic. Hemodynamic ischemia, A2A embolism, and perforated ischemia. Hemodynamic ischemia lead to the watershed infarction, A2A embolism lead to the cortical infarction, and perforating branch occlusion lead to branch arteriomatous disease. Medical treatment is indicated for all mechanisms, but direct surgery, bypass surgery, is effective only for hemodynamic stroke. Endovascular therapy is effective for the hemodynamic stroke and A2A embolism, but not for the perforated ischemia. It is necessary to consider the mechanism of the lesions in each case to determine the indication for the treatment. Here is a case of left M1 stenosis in a 73-year-old patient. The stenosis was so severe that it was caused by hemodynamic stroke. Several CBF is markedly reduced. A detailed angiography showed the perforator, lenticular artery very close to the stenosis. If PTA is performed at this location, plaque shift may occur and occlude the perforator, leading to cerebral infarction. So we choose a bypass surgery. The postoperative course was good. Next case is 66-year male, left M1 stenosis. This is hemodynamic ischemia. Angiogram show M1 distal stenosis and not close to perforator. We performed bottom PTA with 2 mm and 2.5 mm diameter gateway, which are carefully dilated. We did not place a stent as it dilated well. The improvement of stenosis was maintained and no recurrence of stroke was observed after 5 years of treatment. Next case is 66-year male, left VA stenosis. Stroke was caused by A2A embolism. The right vertebral artery is hypoplastic, and the stenosis of left vertebral artery is very severe. First, we dilated the stenosis with 2 mm and 2.5 mm gateway, but after some time, restenosis occurred and shown here. So we implanted a wingspan stent. Post-dilatation was also performed and a good dilatation was obtained. We have been following him for 70 months and there has been no recurrence of stroke. Last case is 63 years male, ICA C3 portion stenosis. The stenosis was very, very severe. We first performed bottom PTA on this region. However, 5 months later, restenosis occurred and cerebral blood flow was markedly reduced. Because of the possible risk of hyperperfusion, we performed bottom PTA only on this region. Cerebral blood flow was normalized after PTA. The patient was retreatment 2 weeks later. We performed bottom PTA first and deployed the wingspan stent and performed posterior dilatation. However, 5 days after the treatment, he had ischemic stroke and presented with left hem paralysis. Angiography showed that the instant thrombosis had occurred. We did the intra-arterial injection of ozagrel and intravenous heparin for 1 week. That thrombosis improved. There is no recurrence of the stroke. I think we should be careful about thrombosis, especially when deploying stent in such a tortuous artery. In conclusion, best medical treatment is the first choice for the treatment of atherosclerotic intracranial artery stenosis according to the current evidence. But it is not always easy to continue strict medical treatment, including smoking, cessation, and exercise. There are lesions that require surgical or endovascular treatment based on the mechanism of symptomization, degree of stenosis, severity of cerebral ischemia, and frequency of strokes. In Japan, the results of bypass surgery are excellent, and vascular treatment should be performed selectively for regions with a high therapeutic safety, and appropriate use of stent should be done. Next topic is carotid stenosis. In deciding the indication for the treatment of carotid artery stenosis, it is first necessary to know the background of evidence. 6 RCTs comparing the outcome of CA and CAS are as follows. Sapphire in 2004 is for the CA high-risk group. EVA3S, SPACE, and ICSS are all included symptomatic regions. CREST included symptomatic and asymptomatic regions in CA normal risk group. And ACT1 included only asymptomatic regions. The details are shown in the table. 3 studies, Sapphire, CREST, and ACT1, concluded that CAS is not inferior to CA. The primary endpoint of these 3 studies included myocardial infarction with maybe one of the factors that led to the non-inferiority of CAS. In meta-analysis of EVA3S, SPACE, and ICSS, and CREST, CAS is associated with a significantly higher incidence of perioperative minor strokes compared to CA. So what is important to reduce perioperative stroke in the CAS? One of the main answers is the question is plaque vulnerability. We evaluated carotid plaque vulnerability by MRI, mainly using T1 weighted image and the time of flight, TOF, MRI source images. Plaque with ISO intensity on both images is a fibrous plaque. High intensity on T1 weighted images is lipid-rich plaque, and high intensity on both images is plaque with intraplaque hemorrhage, which is judged to be the most unstable. This is a video of CA. Unstable plaques may have leakage component is inside, like this. If CAS is performed on such regions, a large amount of debris may be dispersed. There are 2 types of stents for the carotid stenosis. These are open cell and closed cell stent. Open cell stent, precise and protege, have each strut deployed independently. So they adhere better to the vessel wall and have a stronger radial force. A closed cell stent, carotid wall stent, have the strut which are strongly connected to each other and may not adhere the vessel wall in the tortuous region, as shown in the figure. Because the strut is closely spaced and the radial force is not strong, this type of stent is more suitable for the unstable plaque. These stents are used properly depending on the plaque characteristics and the shape of the vessel. The most standard method of protection is distal filter protection. Filter devices included filter wire easy and spider FX. The advantage of this method is that cerebral circulation is maintained, so suitable for the patient with low tolerance to the cerebral ischemia. This disadvantage is smaller debris than filter pore, with pass through the filter, and slow flow and no flow phenomena may occur if the large amount of debris is liberated. So this protection method is not suitable for the unstable or high volume plaque. If no flow and slow flow occurs, we must correct debris with aspiration catheter. We present a case of asymptomatic lesion in a 62-year-old male. MR angiography showed severe stenosis in the left carotid artery. On the plaque imaging, filter plaque is iso-intensity on both T1 weighted and the time of flight images. I think this is a stable plaque. It is suitable for the CAS. IMP specs show the decreased cerebral blood flow and cerebral vascular reactivity in the left hemisphere. So this patient have severe cerebral hemodynamic compromise. This video shows the treatment. Angiography shows severe stenosis of carotid artery. Blood flow in intracranial ICA is found to be delayed compared to the ECA. The filter wire EZ is advanced under the roadmap, passing through the stenosis and opening at the distal ICA. This ring is a filter. We do a pre-dilatation with a 3 mm diameter balloon to create a path for the stent to pass through, which is dilated for 30 seconds to 1 minute. The stent is guided. It is deployed after proper positioning. The stent is placed from the ICA to CCA. The size of stent is matched to the diameter of CCA. Then the stent is post-dilated. This is a post-dilatation balloon. It should be noted that excessive post-dilatation may cause plaque protrusion. A balloon of 3.5 to 4.5 mm is usually chosen. Angiography showed that the carotid artery was dilated. In AP view, it is sufficiently dilated to show that is an oval dilatation. Finally, the filter is retracted and retrieved. Once again, carotid artery dilatation is confirmed. The blood flow in intracranial ICA was markedly improved. Another method of protection is proximal protection. This is a method of reversing the blood flow in the ICA and returning it to the vein. The advantage is that the effect of protection is strongest. The protection is complete even before the device passes through the stenosis. The disadvantage is that the procedure is complicated. Cerebral ischemia may occur during procedure in cases without ischemic tolerance. This is a picture of the working table of the flow reversal system. Blood flowing from the guiding catheter through the filter into the femoral vein. One of the top topics of CAS is introduction of the next generation of micromesh covered stents. In order to suppress plaque protrusion in the cases of unstable plaque, this stent has a double structure of conventional stent and micromesh. These are Seagard, Casper, and Gore stents, each with a different structure. Among these, Casper was approved in Japan at the the end of 2019, and it has become popular now. In 2018, the result of meta-analysis on outcomes of micromesh covered stents are reported. Although the number of symptomatic lesions was low, Casper was used in about half of the patients. Any stroke and death within 30 days were very low, 1.44%. It is expected that the indication may be expanded while ensuring the safety of CAS. Finally, we present a case of Casper stent, a 67-year-old symptomatic carotid stenosis with very high intensity on MRI plaque, T1 weighted images. Because the plaque was expected to be lipid-rich, we decided to use a Casper stent. Angiography showed a severe stenosis with high volume plaque. After pre-dilatation, a 9mm diameter Casper stent is deployed. This is a closed cell stent with a fine mesh, so it does not open as fully as open cell stent. Post-dilatation is performed. Just to be safe, the common carotid artery was occluded, and the balloon and the blood was aspirated. Good dilatation was obtained, and post-operative course was good. In conclusion, since most carotid treatments are prophylactic, good outcomes are always required. The key to maintain a good outcome is to make a procedure a winning game by making appropriate decision on indication and taking adequate measures against treatment risks. Thank you.